less than 300 is low. Normal reference range for testosterone is usually between 300 and 900 in most labs, so less than 300 is low. Rest of his labs, including pituitary hormones, prolactin, FSH, LH, CBC, kidney function, thyroid, parathyroid, everything else is normal. Bone density showed T-score in the spine minus 1.9, femoral neck minus 1.6. Okay, so here we have relatively young, 56-year-old man whose only abnormality is low testosterone. It seemed to fall into this category of idiopathic hypogonadism. It doesn't seem to be associated with any other pituitary abnormality or any other condition. It is not that uncommon, especially you see more of that in diabetics. So, and he does have osteopenia. His lowest T-score is minus 1.9. So the question is, what is the most appropriate treatment option for this patient? Just give him Viagra. He does have ED. Started testosterone replacement, as well as bisphosphonate, or maybe consider more potent therapies such as the denosumab or zoledronic acid. Okay, so let's see how we did here. Wow. Either I make this very easy. No, I think the answer is you guys are doing really great. So I'm very proud. Everybody picked the right answer. Okay, and the take-home message here is that men with newly diagnosed hypogonadism and that have borderline high risk for osteoporotic fracture, basically in that osteopenia category, they should be initially treated with testosterone treatment first. They don't need to start bisphosphonate therapy. They should first have their testosterone level corrected, because testosterone replacement increases bone mineral density and improves shown to improve the especially lower extremity strength in hypogonadal men. This patient should have repeat bone density in 1 to 2 years. And if he continues to lose bone despite the testosterone treatment, at that point you should consider additional therapy. But the first line treatment in hypogonadal person is the hormone replacement therapy. Thank you so much. This is my last slide, but we definitely have a few more minutes for questions.
Thanks very much. As the microphones are coming forward, I've noticed some of my colleagues putting patients on teriparatide for 1 year and then taking a holiday to reserve the second year for later. What do you think about that idea?
Okay. Since I practice in Washington, D.C., and FDA is only 5 miles from my hospital, I have to immediately say that is FDA off-label use of that medication. I have not done that. To my knowledge, there is no good science, about it. People are getting creative. Some people think that the restriction 2 years is too strict anyways. I know there are 3 people that, again, off-label use it past 2 years. Most insurances may pick on that and won't approve it. So again, personally don't have experience with that, but it's only FDA approved for 2 years, and it's studied as a consecutive treatment.
And then you showed 10-year safety data for denosumab. Do you personally just continue denosumab indefinitely? Do you stop at 10 years?
Well, it's kind of the same question we asked ourselves with Fosamax. I mean, Fosamax alendronate was one of the first bisphosphonates. We had some other ones a while ago, but probably the oldest one that was most widely used. And, after it's been on the market for 10 years, people started asking, okay, so what do we do? Then the 10-year data came, and then we continued to use further. Now we have more than 20-year data. I think, again, like with most medications, and you probably got a feeling already, I'm very conservative. My goal is always the lowest amount of medication at lowest possible dose for the shortest possible period of time. However, If you are treating osteoporosis and patient is still osteoporotic, well, as long as they have osteoporosis, if it's a chronic condition, if it's still there, it makes sense to continue treatment. Once when you improve the bone density and they are out of osteoporotic range and you corrected other risk factors, if you feel comfortable enough, with drug holiday, absolutely, it's reasonable. But there are some patients that need the therapy for more than 10 years.
So I asked this question of the other endocrinologist who was here earlier in the conference. Do you check 25D or 125D?
Okay.
I've heard it both ways.
Great question. Actually, there should be only one. The correct answer is, and this is a question I ask always my medical students because I also teach in medical school. Most patients that have normal renal function, they only need 25 vitamin D. 25 vitamin D reflects the vitamin D stores. The only time where we do check 125 in addition to 25 is patients with renal insufficiency or as a part of workup of hyperparathyroidism. Because in hyperpara, you have one of the hallmark is in addition to elevated calcium, you have also elevated 125 vitamin D. So you may have low 25D and high 125D in a patient with hyperpara. And it is not uncommon that patient has more than one condition. So a lot of times we have patients referred to us for evaluation of hyperparathyroidism, but they also have concomitant vitamin D deficiency, which makes the diagnosis, a little trickier because you have two conditions that are driving calcium in opposite direction. Vitamin D deficiency typically will cause low calcium. Hyperparathyroidism will cause high calcium. Low vitamin D deficiency with 25 will be low. In hyperpara, 125 will be high. So when you combine them together, often you get the overlap. So once when we see low 25D and we suspect hyperpara, the first step is always replete the vitamin D stores, reassess the patient at the point where now 25D is normal. But for most of your patients, just 25D is sufficient. As I said, Medicare is already often upset that we even check 25D, so no need to order 125.
And then the companion question, cholecalciferol or ergocalciferol? Okay,
great question. I was going to put the slide, but then I can't put every slide on every topic. But there are studies, and Dr. Michael Holick is one of the authors of one study that showed that cholecalciferol is better than ergocalciferol. So the ergocalciferol is the 50,000 units oral form that, like in the hospital, that's the one we have. We don't have cholecalciferol. In the hospital, 50,000, we only have 1,000, 2,000. Patients can get 50,000 of cholecalciferol in the pharmacy, but ergocalciferol is the one that is given by prescription, and some patients would rather just, if it's prescription, then they pay less. So some patients will prefer ergo. My preference is cholecalciferol for more patients. Cholecalciferol only comes as an oral. It doesn't come as an IV that's another, or IM. Ergocalciferol used to be available IM. It's not anymore in this country. So for most of your patients, outpatients, cholecalciferol that's D3. And the dose may vary as we talk from anywhere from 1,000 per day to 5,000 per day. Sometimes patients panic and say, you want me to put on 50,000? That's going to cause the problem. The data on vitamin D overdose and toxicity, and it is extremely rare. In 20 years, I have not seen one single case of vitamin D toxicity. I have seen a patient that by mistake was discharged from the hospital back to nursing home on 50,000 units of vitamin D, and instead of weekly, nursing home prescribed it wrongly and put patient on daily. Fortunately for patient, they got readmitted 2 weeks later, but for 2 weeks they were getting 50,000 of ergocalciferol every single day. Their 25D was 140. However, calcium was still normal. So to cause severe hypercalcemia from vitamin D toxicity, actually, it's hard. It's not that easy. So, you can reassure your patients that a lot of them are worried that's vitamin D toxicity is quite rare.
Is there a particular patient type in whom you would, instead of going to bisphosphonate first, you would go to denosumab or teriparatide, do that first, and then go to bisphosphonate?
Yeah, absolutely. For patients with severe, so the denosumab or the anabolics such as Forteo or Tymlos are recommended for patients with severe osteoporosis, and that's typically defined as a T-score of -3 or more negative, and patient that already had significant fracture. So those are the patients that we would initially go with those agents. In real life, sometimes that's a little tricky because to satisfy the insurance requirements. And I hope I'm not boring you with this, but since as a practicing physician, this is my daily life, getting prior authorizations. And insurance often wants patients to go through step therapy, and the first step they want them to try and fail bisphosphonates. But there are situations where we would rather patient get the stronger drug first, and then we follow with bisphosphonate.
In terms of the guidelines, so I forget which one, but one of the guidelines committees says that osteopenia plus fragility fracture equals osteoporosis. Do you subscribe to that idea?
Yes, the fragility fracture, I think most endocrinologists subscribe to that idea. I think, again, at the end of the day, it's all about fractures. And we know fracture begets fracture. So once patient had fracture, fragility fracture, that patient should be treated as any osteoporosis patient. Correct.
One of your slides mentioned an alendronate dose daily that was approved for prevention. Is there a convenient weekly dose that's approved for prevention?
I think some people use, trying to think whether there is one. To be honest, most of my patients, some patients that I've seen for prevention are by rheumatologists that are using prednisone chronically.
This is why I'm asking you this question.
Yeah. Personally, I'm trying to think. None of my patient is on a prevention dose like weekly or monthly. Most of the patients I have are treated for osteoporosis, so I don't know on top of my head. 35 instead of 70, yeah. I think I've seen that prescribed by rheumatologists.
Is there anything special about the end-stage renal disease patients?
So great point. So bisphosphonates, maybe I didn't emphasize that, but the creatinine clearance of 35 or below, it's contraindication for bisphosphonates, and that applies to both oral and IV. So that becomes an issue in some older patients with renal insufficiency. So the good news there is that denosumab or Prolia can be used in that situation. There is no renal cutoff for denosumab. So that would be one situation where we would use denosumab rather than bisphosphonates, renal insufficiency.
There's a question on the polling software about a Turner syndrome patient who is premenopausal or 50 years old, but has a low Z-score. Mm-hmm. Anything particular about that type of a patient?
So the Turner premenopausal patients, as I said, none of the bisphosphonates or other osteoporosis treatments are approved for premenopausal women. Turner syndrome patients often they need a hormone replacement therapy. So probably we would use that calcium, vitamin D, exercise, and